Hi, good afternoon, everyone. Welcome to Neurology Grand Rounds. We seem to be missing our residents right now, and I'm wondering if they went to the wrong room.
They're on their way.
They're on their way. Okay.
We got word they're on their way.
We're also missing the food, which hopefully also went to the wrong room. So I apologize for that. I'm John Weinstein, and co-director of Neurology Grand Rounds for the second year. And we Chris and I are really excited to start this new season. We have a lot of very distinguished lecturers coming from both all around the United States and also within the University of Washington community. So we want to really strongly encourage everyone to attend, and we look forward to a great fall season. I'll let Chris add a few comments.
Yeah, so again, welcome to the start of the Grand Round series, and as John mentioned, we're really excited about the lineup we have this fall and in 2017. I want to thank specifically Megan Shade and Jessica Valoy, Nee Kleinbeck for their help organizing this, as well as all the faculty that agreed to give talks and arrange distinguished outside speakers. And today's speaker was organized by Dr. Weiss. We have James Dyck, and I'm going to let Dr. Weiss provide a more formal introduction for him.
I'm excited to introduce Dr. James Dyck, who is full professor of the Mayo Clinic, and he is also the head of the section head for peripheral nerve group there, the head of the peripheral nerve fellowship program. He runs the neuromuscular pathology laboratory, and Dr. Dyck has strong roots to the Seattle area. He did his internship at Virginia Mason Medical Center after doing his medical school, going to medical school at University of Minnesota. He also has very strong roots to the Rochester area. His father is Peter Dyck, who I've always held in very high regard, who's been very focused on the question of CIDP, and Jim has followed somewhat in his footsteps. And so Jim is very interested not only in inflammatory neuropathies, but also in diabetic lumbosacral radiculoplexus neuropathy. That he's really written extensively on those subjects. The old term for that is diabetic amyotrophy, of course. And he also has extremely strong interest in peripheral nerve pathology as a whole. He's published countless, probably over 120 peer-reviewed manuscripts in all of these subjects and more. He is the section head for the neuromuscular section of the American Academy of Neurology, and is an editor on the editorial board of the Journal of Neurology, Neurosurgery, and Psychiatry, and now Muscle and Nerve. And he has been a guest speaker at numerous international and national meetings on these subjects, and we're very lucky to have him here today. He's sort of in between. He's taking about an hour to 2 hours. 2 hours from his vacation to give this talk. He's been here for a couple weeks, I think, with his wife, who's from Seattle. And he's going to give us a talk on, I have to look at the title because it's a mouthful, Autoimmune Polyradiculoneurolopathy and Novel IgG Biomarker, a novel IgG biomarker in workers exposed to aerosolized porcine brain. And if there's anybody to blame for the subject, which I don't think anybody would blame me for, because it's such an interesting subject, it was my idea to have him give this talk.
Thank you. See if I have a neuropathy myself, I can figure out how to put this thing on. Should have looked at it more. No, I need help, so. Okay. Thank you very much. Well, I want to thank Mike for inviting me here, and thank you all for coming. Seattle is like a second home to me. My wife grew up in Magnolia, and I came here frequently on vacation. I did my internship at Virginia Mason, and so it's nice to be back in Seattle. It's my first time officially here on business, though I come frequently, and I have a lot of old friends in the audience, so it's good to see Dr. Bird, Dr. Ferenga, Dr. Miller, and others. And thank you all for having me here to talk to you today. I'm going to talk to you about a subject that probably you're not going to hear a lot from other people. It was an interesting epidemic, if you will, that happened just down the road from us. And I'm going to start by presenting a couple of cases to sort of get you into the frame of this. So the first one was a 51-year-old woman I saw. In April of 2007, she developed subacute symmetrical distal tingling in her feet, followed by numbness and weakness. She had hypersensitivity in her feet. She felt like she was walking in sand. By 3 months, her symptoms ascended her legs and then her thighs with patchy areas of numbness. She noted them when shaving her legs. She had difficulty climbing steps. She needed to use her hands. She had no fevers, chills, weight loss, dry eyes, dry mouth. Her past medical history essentially was unremarkable. She didn't smoke. She rarely used alcohol. She worked in cutting meat off of hogs' heads at a pork processing plant. On examination, she was awake alert, her cranial nerves were normal, and she had diffuse muscle weakness in proximal and distal muscles. Now, this is a weird numerical system that you're probably not used to. This is the Mayo Clinic grading system. 1 is 25% weak, 2 is 50% weak, 3 is 75% weak, 4 is paralyzed. It's a linear system. So she had mostly 1 to 2 weakness, 25 to 50% weakness in proximal and distal muscles. She had reduced sensation to pin, touch, vibration in fingers and toes. She had reduced reflexes in the upper limbs, absent reflexes in the lower limbs. She had an ataxic gait. She had difficulty with tandem. She couldn't walk on her heels and toes. She had a Romberg sign. So this is some nerve conduction tracings, and they were fairly striking in that, and most of you probably aren't EMGers. I'm going to show you a bunch of EMG tracings, so I apologize for that. But were rather unique in that these patients had very long distal latencies. So her distal latency from her perineal is 16.2. In our lab, it should be less than 6.1. But her conduction was 46 meters per second, so that was normal. So the very distal terminal parts of the nerve were abnormal, but the middle part of the nerve was conducting fairly normally. Her F-wave latency, so you're shocking at the muscle, that's going back up into the spinal cord and coming back down the same nerve pathway. That was prolonged at 69.9, using her conduction velocity that should have been at 54 milliseconds, so that was also prolonged, which implies there's some very proximal slowing. So these nerve conductions showed very slowed part of the distal nerve and slowed part of the proximal nerve, with the middle part of the nerve conducting at a fairly normal velocity. This is her sural response. This is a sensory response from the back of the leg, and it's normal. Going on to her ulnar motor response, it was rather similar to the lower limb response. The distal latency was long at 5.1, should be less than 3.6, but the conduction was normal at 55 meters per second. And the F wave here was prolonged at 36, it should have been less than 28. So again, a slowing in the distal part of the nerve and slowing in the very proximal part of the nerve, where the middle portion of the nerve was fairly intact. Her blink response, R1, was 28.4. This should be less than 13 milliseconds, so this is very prolonged. All right. So her needle examination showed some scattered fibrillation, large motor unit potentials, reduced recruitment, and this was interpreted as showing a moderate motor predominant and distal predominant demyelinating polyradiculoneuropathy. Her autonomic reflex screen was normal. Her thermoregulatory sweat test was normal. Her quantitative sensation showed borderline vibration sensation, but her cooling and her heat pain were normal. Her spinal fluid showed a protein of 125. Glucose was normal, 1 white cell. And she had multiple markers of positive rheumatological serology. So her ANA was positive at 7.1. Her ENA was positive at 91.9. Her SSA was 121. And these serologies would make you think she had Sjogren's syndrome. Going along with a sensory predominant neuropathy, it seemed very likely she might have had Sjogren's syndrome. Her hepatitis B surface antibody was positive, the rest was negative. MRI of the spine showed thickened and enhancing nerve roots and dorsal root ganglion. So we did a sural nerve biopsy, and these are teased fibers from her sural nerve. The top two fibers show Wallerian degeneration. The fiber in the middle with the arrows on it shows an area of segmental demyelination. She had perivascular inflammatory cell collections, small, but they're shown there. Her density of myelinated fibers was fairly normal. She did have some regenerating clusters, as you can see, if I can get that over there, right there, right there. She had some accumulation of organelles right there. Showed mildly increased rates of axonal degeneration and segmental demyelination, occasional regenerating profile, small collections. Overall, it suggested an inflammatory process. She was treated with a gram of IV methylprednisolone 3 times a week for 1 week and then once a week for 11 weeks. With this, she felt 98% better, her pain resolved, her gait improved, her strength improved, and her numbness improved. All right, so that's the first case. The second case is a 28-year-old Hispanic man who worked at the same pork processing plant for 1 month. After working there for a month, he developed headache, malaise, back pain over 1 week in December of 2006. He woke up with sudden onset of inability to move or feel his lower limbs. He had severe weakness. He could not urinate or have a bowel movement. His past medical history was negative. His job was to remove pig brains. He would insert a hose into the base of the head, and he would put in compressed air, and it would be blown in, and the brain would come out in pieces and partially aerosolized and would splatter about 10 feet. He would wear goggles, but no protection over his nose or mouth, and he would often get splattered by pig brain in the face. His neurologic examination was consistent with a myelopathy at the T6 level.
Was he happy at his job? And let this guy do it, right?
Well, you can see, he continued to go back to his job, as we will learn. So he had 350 white cells, 1 oligoclonal band, 2,000 red cells, cytology was negative, protein of 75, glucose of 54. MRI of his thoracic spine showed increased T2 signal in the entire thoracic cord without enhancement or enlargement. And there is his T2 MRI of his cord. He was admitted to the hospital, diagnosed with transverse myelitis, treated with IV methylprednisolone, and with this he had slow improvement over 4 to 5 months. He began to walk again. He regained urinary and sexual function. At 5 months, he felt 80% back to normal. At that time, he returned to his work. And again, he started extracting pig brains. And that's about 6 months after the initial onset of his illness in May of 2007. Within weeks, he had recurrent headaches, fatigue, pain, urinary problems, walking difficulties, and a sense of overall weakness. He quit his work after 1 month because of his worsening symptoms in June 2007. While off work, his symptoms gradually improved. After being off work a second time for 4 months, he again returned to the same job in October of 2007. Within 1 month, he developed lower limb pain, weakness, walking difficulties, urinary retention, and erectile dysfunction. He then was evaluated at the Mayo Clinic, and he was one of the first patients identified with this new syndrome that we are discussing today. All right, and there's his MRI of the lumbar spine showing thickened nerve roots. All right, so this is his nerve conductions, and very much like the first patient, this is his tibial. His distal latency is 13.2, that is prolonged, it should be less than 6.6 in our lab. And again, his conduction velocity is 45 meters per second, which is normal. So it's the very terminal part of the nerve that seems to be involved. His F wave is 101 milliseconds, it should be less than 58 milliseconds. And with that normal conduction velocity, again, he has a lot of slowing the very proximal parts of the nerve. So there's a very stereotypical pattern of the very proximal parts of the nerve, the very distal parts of the nerve being affected in these patients. His Searle response was normal. His ulnar, again, showed a long distal latency with a slightly slowed conduction velocity, but relatively preserved conduction velocity. And his ulnar F wave was prolonged compared to the F estimate, again showing proximal slowing. His median sensory showed a long distal latency, and his trigeminal blink response was also prolonged, but not as long as the lady's in case 1. His was 15.8, should have been less than 13. So his EMG was interpreted as showing a diffuse demyelinating polyradiculoneuropathy with marked slowing in distal and proximal nerve segments. His quantitative sensation showed vibration abnormality at the 99th percentile and some hyperalgesia to heat pain. He was treated a second time with IV methylprednisolone, 1 gram 3 times a week for the first week, and then once weekly for 12 weeks. With this, his symptoms improved but did not resolve. His pain, gait, urinary, and sexual functions improved. All right, so I'm going to discuss with you an outbreak of a sensory predominant polyradiculoneuropathy in pork plant workers. In September of 2007, Mayo Clinic Spanish interpreter and a Mayo Clinic family practice physician noted neurologic symptoms in workers from a pork processing plant in Austin, Minnesota, which is about 30 miles from Rochester, Minnesota, where the Mayo Clinic is, and contacted Mayo Clinic neurologists who had seen these patients, and I was one of those neurologists. In November of 2007, 12 cases of a stereotypical neuromuscular syndrome was reported by us at the Mayo Clinic to the Minnesota Department of Health as a suspected new outbreak. In December of 2007, an association between pig brain removal and neurologic symptoms was recognized, and the plant voluntarily terminated the brain removal process. In March of 2008, the most recent case was recognized. So the 21 cases were noted among 1,200 workers. That's about 1,750 cases per 100,000. When you compare that to CIDP, the rates are 0.5 to 2 cases per 100,000 per year. In AIDP, it's similar, 1.2 to 1.9 cases per 100,000 per year. So these rates are much increased over other inflammatory neuropathies. All the cases were patients who worked in the warm room. And the warm room was the butchery room where they cut the meat up before taking it into the plant to process it. So there were 15 cases, all who worked in the warm room. There were 56 non-ill head table workers who acted as controls, and there were 49 non-ill warm room workers who didn't work at the head table, who also acted as controls. The affected workers were all more likely to work at the head table, where the brain removal process occurred, or remove brains or muscles from the back of the head, or work within 10 feet of the brain removal location. Initially, we recognized 15 cases. Eventually, we recognized 21. So here is a diagram of the warm room. And right over there, that green dot, is where the brain removal process occurred. The yellow boxes represent stations where affected workers were. So you'll notice they were all clustered around this head table or within close proximity to it. Only one worked a ways away, and that person was best friends with somebody who worked here and spent all of her time over there.
Jim,
Yeah.
I don't know if you're going to explain it, but so can you mention why these people were blowing out big brains?
Yeah, why were they removing the brains at all? It's a good question. Apparently, there is a market for pig brain consumption in Asia. And so they were essentially sending these all to Asia. And they get everything they can out of the pig carcass, and because there was a market, they used to apparently cut the skull open and remove the brain, but that was much more labor intensive and much slower. They found it was much more efficient just to blow it out, and I guess they don't need the brain intact. They would just, process. Yeah.
So what happens to the people who eat the brain?
So I don't think anything happens to the people who eat the brain.
It goes through the GI system.
It's a completely different type of exposure. So this is a fresh, these are fresh carcasses, pigs that have just been butchered. So this is fresh tissue, non-processed, non-anything, and we are aerosolizing fresh pig brain. All right, so the plant processes about 13 hogs per hour. It increased its line speed in 2003 and 2006. Since 1998, compressed air has been used to remove the brains. Before that, as I said, they would just cut them out. A tube, as I've sort of mentioned before, was placed in the base of the head, the foramen magnum. The brain was liquefied, extruded through the foramen magnum into a pail. Splatter and aerosolized droplets of brain material were created, and the workers did not wear face masks. And here is a picture of the actual, this is the real place, this is where it happened. So, this is a pig head, there's the eye, the snout, the base of the head. This is the tube that was used, placed in the foramen magnum, and then blow the brain out, throw it there. So, the Minnesota Department of Health concluded that there was a novel polyradiculoneuropathy associated with the removal of porcine brains using compressed air. They felt that an autoimmune mechanism was likely. They concluded that abattoirs should not use compressed air to remove brain and should not aerosolize CNS tissue. And they concluded that respiratory mucosal exposure was likely the root of this immune-mediated illness, not the GI tract. All right, so who were the workers who were affected? And what jobs did they actually do? So 2 actually did brain extraction, 8 cut meat off the heads of pigs, 6 removed other parts of the pig, 3 were meat inspectors, and 2 had various jobs in the kill room and intermittently packed brains. So 21 cases were identified from a Minnesota plant, and they all had the sensory predominant polyradiculoneuropathy. 3 of them additionally had CNS disease. 1 had an aseptic meningitis, 1 had a meningoencephalitis, and 1 had the transverse myelitis, and here's the case I discussed with you. Also, 3 cases from an Indiana plant that used the same pig brain removal process were seen and confirmed to have a similar disease at the Mayo Clinic. So they traveled and came and saw us. All 24 cases worked either in brain removal area or in close proximity to it. So all the patients came and were seen by myself, Jennifer Tracy, and Dan LaChance with the standard evaluation. They had neurologic examination, nerve conduction studies, EMG, quantitative sensory testing, autonomic reflex screen, thermoregulatory sweat test, MRI of the spine, spinal fluid evaluation, and routine blood work. 24 cases, 21 from Minnesota, 3 from Indiana. The average age was 33 years. 58% were women, 42% men. 59% were Hispanic, predominantly Mexican. And that was part of the issue with this whole thing, is a lot of these people were illegal immigrants, and they tended to disappear over time after they got this illness. And you asked, was he happy in his work? I think part of the reason it was the only work that he could get, so I don't think he was particularly happy in it.
Jim, are those proportions similar to the overall proportion of Hispanics in the plant?
The distribution in gender and ethnicity was representative of the population of the plant. So yeah, it was.
Oh, you're...
No, it's okay. You set me up. I couldn't resist just reading my slides. I apologize for that. All right, so there was a stereotypical sensory predominant polyradiculoneuropathy. What were their symptoms? They had pain, they had tingling, they had fatigue and weakness, and they had walking difficulties. And so they would always say how weak they were, and you often would examine them and not find them to be as weak as they seemed. And so if you ask the patients, what's your biggest problem, they would often tell you weakness. But you actually examined them, they often weren't that weak, and it seemed to be almost this disconnect. But they had this terrible sense of fatigue with this, that they couldn't do anything, and they felt very ataxic, and they had a lot of just pain and aches. On examination, they had stretch signs, sensory loss, weakness, but again, not as severe as their symptoms would suggest. Their reflexes were reduced, and they often had this antalgic gait. All cases but one reported their onset between December of 2006 and December 2007. 2 patients whose primary job was the brain extraction were among the first to develop the symptoms, and the technique of pig brain removal with pressurized air was stopped in December of 2007, and that's when the outbreak began. Yeah.
Was there something different about the pigs that it started then and not before?
So I don't think it started then. I think these workers were replaceable, and they were largely illegal. And so I think we recognized it at a certain point. And at that point, we got all the workers we could find, and the ones that had gotten sick before had disappeared and were gone. And that was clearer to me, and I'll come to it in a bit, but at the Indiana plant, because they frankly, one of the people I saw at the Indiana plant, she got her job as a pig brain removal because the other person got sick and had to go off work, and so they put her in her place. And the foreman said to her, well, everybody who does this job gets sick and they all leave. And so it was essentially recognized that there's something bad about doing that job at the Indiana plant, but nothing was done about that.
How long were these individuals doing that brain removal process? And did it relate to how long they were exposed?
Yeah, well, so not very long.
Not very long.
Yeah, and as you saw in the case I presented to you, he had 3 periods of working doing that. Each of them lasted a month. And then he got sick and he would go off work, and then he'd go back to work, and he'd last a month and get sick and go off work again. So, and again, I don't have a detail, I'm not part of the Minnesota Department of Health, so I was seeing these patients at Mayo Clinic. I wasn't allowed to go off to the plant. The Minnesota Department of Health people were. So all my information was sort of secondary, talking to patients and getting it from what they're telling me, not by actually talking to plants and things like that. All right. So 3 cases presented with CNS symptoms before the onset of their polyradiculoneuropathy. 1 case had a meningoencephalitis with status epilepticus requiring anesthesia. A brain biopsy showed perivascular and parenchymal T and B cell infiltration. 1 case had transverse myelitis, and I've talked to you about that case. And 1 case had an aseptic meningitis with severe headache and mild CSF pleocytosis. So their initial presentation, 71% presented with pain as their initial symptom, and 29% presented with headache as their initial symptom. 29 also had tingling at onset, 24% had numbness at onset, all that was in the lower limb, and all patients had this sense of fatigue and weakness, which is very common. 95 presented with a subacute onset. 1 that I've talked about with the transverse myelitis presented as an acute onset. 1 had an encephalopathy with seizures, and 2 had relapsing courses. So at time of presentation, 95% had pain, 86% of the lower limbs. Burning and aching were the most common. They often had this head and neck pain. They move their head around, they often get this sort of radiating pain down. 59% had positive nerve stretch signs. 81% had weakness on examination, but most of that weakness was mild. 81% at the time of evaluation complained of tingling and sensory loss on examination. They almost all had gait difficulty. 4 had bowel bladder symptoms. 2 had facial nerve dysfunction. 2 had syncope. So this presents as a subacute syndrome of lower limb pain, aching, burning, numbness and tingling, generalized heaviness and fatigue, difficulty walking. On examination, mild sensory loss and nerve stretch signs are common. So objective weakness was common, but usually mild. The examination was mild and less severe than the subjective symptoms. And I think clinically it's best described as a sensory predominant polyradiculoneuropathy. And I'm saying that it's sensory predominant based on their symptoms and findings, not on their nerve conductions, which are motor predominant. So there are other plants that also use the same process, and these were in Nebraska and Indiana. And a similar syndrome was reported to occur at both of these plants. And 3 patients from Indiana came and were evaluated by us. There's a 28-year-old woman from El Salvador. She'd worked at the Indiana plant for 3 years, removing pancreas and lungs. In May of 2007, she replaced a worker at the head table who had gotten sick and had to leave her job. She started working cutting out tongues and removing brains. By November 2007, she developed numbness in the hands, feet, lips, and tongue, developed right grade and left calf pain, constant ache, headache, severe fatigue, leg weakness, lost 30 pounds in weight. She was hospitalized in December 2007. Her spinal fluid protein was greater than 300. Her nerve conductions EMG showed a demyelinating polyradiculoneuropathy, and they wondered if she had Guillain-Barré or CIDP. She was treated with IVIG and then methylprednisolone. She had gradual improvement, still residual fatigue, pain, and numbness. In March 2008, her repeat CSF was a protein 128 and 12 white cells. And these are her nerve conductions at Mayo Clinic. And again, very similar to what I've shown you before, long distal latencies with a normal conduction velocity from the perineal. Her searle was normal. Her trigeminal blink response was prolonged. Again, it was interpreted as a demyelinating polyradiculoneuropathy involving very proximal and very distal parts of the nerve. So 3 Hispanic women came and saw us from Indiana, ages 28, 28, and 41. All of them were directly exposed to brain removal with pressurized air. 2 had subacute onset. 1 was acute and was wheelchair dependent. All 3 were hospitalized with their illness. All 3 had upper and lower extremity pain. All 3 had the sense of fatigue and sense of weakness. All 3 had walking difficulties. 2 had headaches. 2 had bladder dysfunction. And they all came and were seen by us after being treated with immunotherapy. So they were partly treated by the time we'd seen them. All of them had abnormal quantitative sensory testing. 2 had abnormal autonomic reflex screens. 3 had abnormal sweat test. Their initial EMGs were abnormal with prolonged distal motor and F-wave latencies. And they were essentially indistinguishable from the cases we'd seen from our Port Worth plant down the road.
Your sweat tests and your autonomic tests were normal in the early cases you showed.
Yeah, so the autonomic and the sweat test were abnormal to some degree, but less so than the EMG. So it suggests more of a large fiber than a small fiber dysfunction, but they were abnormal to some degree as well. 95% had markers of systemic inflammatory, abnormal SED rates, CRPs, ANAs, ANCAs, rheumatoid factors, etc. Spinal fluid were elevated in 86%. Average protein was 134. 3 had pleocytosis. So I've been showing you examples of this, but the nerve conduction studies showed evidence of very proximal involvement and very distal involvement. Long distal motor latencies, long F-wave latencies, long trigeminal blink responses, absent distal snaps. So the sensories for the medial plantar were often gone, but preserved sural snaps. And the nerve conductions in the middle section of the nerves tended to be fairly normal. The trigeminal blink was often prolonged. And this is just a summary of all of that data from these patients, showing you the long distal latencies, long F-wave latencies. So into the quantitative sensation autonomic stuff, 19 of 21 QSTs were abnormal. Of those, 15 are large fiber, were vibration, and then lesser numbers of cooling and heat pain. 11 of the 16 autonomic were abnormal. All of them were decreased sweating to the pseudomotor postganglionic impairment, and 14 of the 19 sweat tests were abnormal, 10 with distal sweat loss in the toes, and 4 with a patchy polyradicular pattern. So here are 2 different patients. On the left, you see a 32% anhidrosis, or on the right, it's just the ends of the toes, or 2% anhidrosis. The areas in yellow are the areas where they're not sweating. The areas in purple are where they are sweating. 3 patients had sural nerve biopsies. They showed mild abnormalities. Mild axonal degeneration, mild segmental demyelination, small inflammatory collections, some hemosiderin. The densities were normal in all, but they had some regenerating clusters in thin myelin and some demyelinated axons.
Did you do any skin biopsies?
Did not do any skin biopsies in these patients. So here are examples of demyelinated nerve fibers in the top 3, axonal degeneration in the bottom 3. There's a perivascular inflammatory collection, more perivascular inflammatory collections, a little bit of hemosiderin on the left with the blue, and some scattered endoneural inflammation. So the top panel on the left, the arrows are pointing at demyelinated fibers. The top on the right is a regenerating cluster. And the bottom row are electron microscopy. On the left, you see a naked axon, the arrows pointing at, and the right is a regenerating cluster. So low rates of demyelination and some nerve fiber regeneration. This is a very small onion bowl, so evidence of D and remyelination. So all the nerve biopsies were mildly abnormal. None of them were terribly abnormal. Mild increased rates of axonal degeneration and demyelination. All had some amount of inflammatory infiltrate. There were small onion bulbs and some naked axons suggesting some demyelination. All right, MRIs. 87% of patients had abnormal MRIs. 76% of the lumbosacral spine. 93% of the cervical nerve root enlargement. Plexus abnormality, lumbosacral in 2 of 3. Brachial in 1 of 1. Transverse myelitis in 1 of 15. And there are pictures of that. All right, so a unique novel IgG biomarker was seen in these patients. So the serum of 24 of 24, 100%, and in the CSF of 12 of 18, 67%. And they stained different neurological areas, including the cerebellum, the midbrain, cranial nerves, and autonomic fibers. And here is examples of that. So it was, yeah.
Does it stain myelin sheath?
I can't answer specifically myelin sheath versus, the rest of this. This is Van de Lenen's contribution to this, and I don't get into the specifics of this too much. But it stains myelinated fibers, both centrally and peripherally. So that's a cranial nerve there, for instance, and these are autonomic fibers there. So in patients 24 of 24, 100% reacted with an average titer of 7680. In the clinical warm room workers, so these are people who are exposed to it but didn't develop the disease, it was positive in 34% of those patients at a lower titer of 1900. And in community controls who had no exposure to this, 0 of them had it from 178. And this is showing the same thing graphically, that only patients and asymptomatic workers who were exposed to the brain developed antibodies, where community controls didn't develop any of these antibodies.
Did any of the asymptomatic controls have studies?
Nerve conduction studies? No. No. So the asymptomatic controls were identified by the Minnesota Department of Health when they went into there, and I didn't have any access to any of those patients. So they were only seen by the Minnesota Department of Health people.
Were there any patients who were studied in a serial fashion to see if the titer diminished?
Oh yeah, no, there were all of our patients as much as we could get them. So we brought them back, and I'll give you some of that data. But we brought them all back as we could. But again, many of these were illegal aliens, and they just disappeared. So we could see them for a while, and they were all gone, essentially.
I assume the pigs were all normal, were they? I mean, before they were killed?
The pigs were all theoretically normal. Again, there are 1,300 per hour that they're processing. So I mean, they didn't undergo rigorous testing, but theoretically they were normal. All right, so an abattoir IgG is a composite of known antibodies, including voltage-gated potassium channel autoantibodies, this abattoir's IgG pattern, and a myelin-basic protein. And different correlations looking at abnormal root MRI, abnormal EMG, weakness, impaired sensation, looking at these different components show that the voltage-gated potassium channel antibodies seem to react the most, the best, if you will, looking at all those different features. So finding an IgG biomarker in the actual cases as well as workplaces controlled correlated with working at the head table or less than 20 feet from the brain extraction site. Myelin-basic protein IgG titers were inversely associated with working distance. So the closer you were working, the higher your titers were. And there was a greater frequency and higher titers in porcine myelin-basic protein than human myelin-basic protein. That argued that it was in fact a reaction against the pig brain that induced this. So here you can see there's this inverse relationship between the distance you're working from the brain removal site and your level of these antibodies, both in the cases and in the workplace controls. And that again shows you it's both with human and porcine, but the actual porcine titers are higher, suggesting that it's a reaction to the porcine. All right, so Van der Lennen and colleagues then developed a mouse model of this. And this was by aerosolizing pig brain tissue to mice. So female 129 SVEV mice were exposed to intranasal porcine CNS homogenate daily, and then they were bled every other week for antibody testing, and then they were weighed, and they had pupillary light responses, fatigable weakness, hot plate nociception, anesthesia susceptibility tested. And they developed a very similar abattoir IgG type reactivity to what the humans, the cases that I've reported to you were developed. And so after being exposed, you can see they developed antibody titer, often at day 56, and they went up from there, and 100% were positive. And when they were given higher amounts of aerosolized porcine brain, their titers rose more rapidly. And when the exposure was ceased, their titers fell.
How do you give intranasal porcine brain to a mouse?
I didn't do it, so I can't actually answer that question. All right.
Did they fractionate the material and look for certain membranes or things?
Yeah, I don't know that either. I'm sorry. I just wasn't doing that part of it. So the intranasal exposure to porcine brain tissue does induce an autoantibody response in mice, which replicates the patient's outbreak. Antibody levels relate directly to exposure dose, spectrum of neural-specific antigens, and spontaneous recover after exposure it ceases. All right, so moving back to our patients. So we followed up with our patients as best we could, The average time to follow up, we saw them multiple times if we could, but looking at the last time of follow-up, the average was 17.5 months from symptom onset, ranged from 12 months to 38.5 months. 7 of the 24 patients received no treatment. 17 of the 24 did receive treatment. They were steroids, IVIG, plasma exchange, Cytoxan, azathioprine, and 7 received multiple different treatments. So symptoms improved with treatment in 16 of the 17 patients, 12 marked, 2 moderate, 1 mild. There was spontaneous improvement with cessation of exposure to aerosolized porcine brain in 6, and 1 was lost to follow-up immediately. We never saw him back.
Do you get the sense that there's quicker, more accelerated improvement in treatment?
Yeah, it's very hard to know. So again, I had better follow-up in the people we were treating than the ones we weren't treating. So, because we pretty much treated people that we could treat. So that, I think that's an impossible thing for me to say. So did we make any difference by treating these patients? Is really the question you're asking. And the answer is, I don't know. I mean, I don't know, because we certainly weren't going to keep half of them on aerosolized pig brain and treat them, and the other half not. I mean, so symptoms measured by the Neuropathy Symptom and Change Questionnaire, which records number of symptoms, severity of symptoms, and change of those symptoms over time. Their symptoms clinically were improved in 22 of 23, and as I say, 1 was lost to follow-up. So the initial number of symptoms was 9.5, and then follow-up it went to 5, so that was improved. The severity of those symptoms were 13, they went to 9.5, so the severity improved. Change means the direction it's going. Negative 9.5 means their symptoms were worsening at the beginning. 12.0 means their symptoms are improving. So clearly change over time after they stopped being exposed and were treated with steroids and IVIG, the change was going in the right direction. And all of them were significantly improved. Impairments, looking at the neuropathy impairment score, also improved. The total NIS was 14 at the beginning and went to 4 at the end, and so that was a significant improvement. Yeah?
Was there any difference between the people who were treated or not, or was it just difficult to say because the people who weren't treated?
Yeah, so that's what Michael was asking, and no, it's okay. And I was specifically told I should repeat all questions I'm asked, and of course I forget all that anyway.
Well, I'm here, I should have heard that question.
Well, no. So again, I will repeat it now. So was there any difference between those treated and those who were not treated? And the answer is I don't know. And so there were 6 or 7 who weren't treated. I think 7 who weren't treated. 6 followed up, 1 didn't, and then 17 who were treated. And I can't tell you the difference. There was better follow-up in the treated ones than the non-treated ones, so we saw them more frequently. And I don't know the answer to that question. I mean, it's an important question, but it's just, I don't know, and I don't want to speculate. What happened to their nerve conduction studies? They all improved. So the prolonged distal latencies, the prolonged epiploid latencies, the prolonged trigeminal blink responses, all improved, and they were all significantly better than they had been before. And here are some examples of that. So here is a distal latency that went from 9.4 on the perineal to 4.4. So it reduced by more than 50%. Here is a an F-wave response that went from 77 milliseconds to 48 milliseconds. So it also was significantly better. Here is another distal latency. This, in fact, was the first case one I showed you. Went from 13.2 to 4.7. So it's markedly better in the distal latency. This, I showed you this one as well. This F-wave latency went from 101 down to 51, so improved by 50%. Here's a medial plantar response that was absent, and after treatment it returned, and it was an amplitude of 15 microvolts, so it went from being not there to being fairly robust. This blink response, again from case one I showed you before, went from 28 to 13.7, so again about twice as good. Similarly, quantitative sensation improved, not significantly, but all vibration, cooling, and heat pain all were better with time. Autonomic reflex screens improved. Thermoregulatory sweat test, 11 of the 17 improved. 3 were the same, 3 were worse, but overall they improved. And here's some examples of this. On the left was early on the right was later on, so the whole feet were anhydrotic originally, and then at the end only the toes. I showed you the picture on the left originally. She had 32% anhydrosis. She went to 0% anhydrosis after treatment. Similarly, the serum IgG markers improved. And this is in 21 patients, 16 received treatments. The serum IgG levels fell below the detection limits in 19 of the 21. And voltage-gated potassium complex fell lower than detection in 12 of 16. But all their symptoms did not resolve, and pain was a long-term problem for many of these patients. So initially, pain was there in 24 of 24. Pain at the final visit was still there in 19 of the 23. Still severe in 7, mild in 12, none in 4. Headaches initially in 20 of 24, headaches in the final visit in 15 of 23. So not all resolved, but it was improved in essentially most patients. So overall, the pain was improved in 18, much improved in 16, a little improved in 2, no better in 5. Headaches improved in 17, no better in 3. So, in conclusion, a stereotypical sensory predominant polyradiculoneuropathy occurred in pork plant workers exposed to aerosolized pig brain. The pattern of nerve involvement, very long distal latencies and F-wave latencies, suggest vulnerability at nerve terminals and at nerve roots. And these are the areas where the blood-nerve barrier is the weakest and then it's most permeable. So this actually makes sense. The blood-nerve barrier is the most robust throughout the length of the nerve, but right at the roots and right at the nerve terminals, it's fairly weak, and this is a potential entry zone for this autoimmune attack to enter the nervous system. All patients' serum had a distinctive IgG biomarker that supports voltage-gated potassium channel dysfunction. Titers correlated with proximity to the brain extraction site. Intranasal exposure to porcine brain tissue induces an autoantibody response in mice, which replicates the pork plant worker's illness. The symptoms, neurologic impairments, neurophysiological testing, and titers of an IgG biomarker improve over time after cessation of occupational exposure and immunotherapy. Complete remission is rare. Both distal pain and headache are ongoing problems, but these symptoms are much improved. Sensory predominant polyradiculoneuropathy in pork plant workers is an autoimmune disorder induced by exposure to multiple porcine neural antigens. And this is the work of a lot of different people, collaboration, Minnesota Department of Health, Van de Lennen's lab, our center. So I want to acknowledge all the other people involved. Thank you all for your attention.
When the deportation task force comes, who's going to work in these plants?
Yeah, no, it's a good question. I mean, yeah, and so I don't know if any of you all know this. In Minnesota, it's kind of common knowledge, but Hormel went through a very nasty strike in the 1980s. And the way they dealt with it, it was sort of skilled and unskilled worker. And they essentially put a wall right down the middle of the plant. And they divided off the part where they're dealing with the carcasses into a different company. And they didn't need to be unionized in the rest of this, where then the processing after the original butchery occurs happens in the skilled part of the plant. And essentially, it's called quality meats or something like that. QPP was the name, Quality Pork Processing was the name of that company. It was owned by Hormel, but it was a different company and they had different rules. And they were essentially, 80% of them were Hispanic and largely illegally illegal. So. Yeah.
And that was fantastic. I enjoyed that. I had a question though about the antigen specificity of the antibodies in this disease. It's targeting primarily voltage-gated potassium channels, not necessarily a myelin-associated protein.
So it targets essentially everything. I mean, and again, I think you really need to talk to Vanda about a lot of that. But you know, so I'm trying to put in what she says into this and be deferential to her. You know, it was actually me who started ordering. I thought this is a weird syndrome, so I started ordering paraneoplastic antibody. And when you got the initial results, everything was positive. I mean, everything was positive. And then suddenly she became aware that something was going on, and then no more reports came out. And it annoyed me a little because, you know, I was ordering this as a clinical test, and she's like, "Oh, this is very cool. This is a research thing." But you know, I wasn't ordering it as a research thing. So, but the message was that everything reacted. And if you think about it, it's, you know, you're exposing you to all this myriad of brain protein that you're inhaling in, and I think in a lot of ways it kind of makes sense what happened to these. The areas where the nervous system is the least protected to entry of these sort of antibodies is at your at the roots and at the nerve terminals, and so you develop this polyradiculoneuropathy. It essentially was an accidental experiment that happened in human beings that this poor processing plant created. Back to your question, I don't really know the answer, but go ahead.
Corollary to that question, given that the antibodies do preferentially target voltage-gated potassium channels, is there any evidence for peripheral nerve hyperexcitability?
Yeah, there you go. No. I mean, so we certainly didn't see anything on the EMGs or anything that looked like peripheral nerve hyperexcitability. I mean, from any of the studies we did or the symptoms they had, I don't think so. Yeah, as for needle exams, none of them reported that sort of thing. Yeah.
So that was a great talk, a great story of medical detective work, public health, and clinical and basic science. I
got the Shepherd Award for the best epidemiological story in the country for the year with this. Yeah, but it was with the Minnesota Department of Health. That was an asterisk in the whole thing. But
so apart from epidemic AMON or something where the Campylobacter, we often don't know what a trigger is for young Ray and some of these. Have these results spurred more efforts to look for environmental exposures as a cause of autoimmune neuropathy?
It's, not that I know of. I mean, people got very excited about this when it happened, and you know, it's fun that Mike asked me to come and talk about this because when this was happening, everybody was talking about this, and there isn't a lot of discussion since then. So it was fun for me to dust off my slides and come back and talk about it again.
That's because it took us 8 years to get you out.
I'm going to go Tom third.
So along the same line, is this kind of brain removal used in sheep and cattle, for example?
So the answer is I don't know. The Minnesota Department of Health and they looked into this and they said they didn't think it was used in other animals besides sheep. You know, I think what happened is somebody at Hormel got this great idea that if we used compressed air, we can get these brains out and it'd be a lot more cheap. And nobody put two and two together, right? You know, so I don't think so.
Just out of curiosity, how many of these individuals were covered by workman's comp? Do you have any thoughts about, I mean, can you tell us any stories about it?
Well, so I think they should have been covered more than, so they are covered by workman's comps. And so some of the meat inspectors and some of the people who were legal got more out of it. But I was appalled by how little they got out of this. And, you know, workman's comp is really, you know, you think of it as workman's comp, but it's also a protection for the companies employing them so that it's going to have a ceiling and it's not going to be too high and they can't come back and sue you and put your company out of business. And almost the story to me in this whole thing was how little protection there really is for these workers, especially when they're illegal aliens and all that. They just, by and large, disappeared and really didn't get much out of all of this. You know, I mean, this is a horrible occupational thing that happened to these people, and they mostly disappeared. Now, I think they did improve with time, But again, they still, most of them didn't feel they were back to normal. I mean, many of these were young people playing soccer and doing things like that beforehand, and they weren't doing that at the end of it.
And they had no objective signs.
Very little objective. I mean, again, I don't want to say none, but you talk to them and they just say, life is horrible, life is terrible, I feel weak, and you examine them and the initial patients I saw here, it's like these people are complaining, what's going on? I mean, it's before I realized this was all going on. And then you get their EMG back and it's very abnormal. And it's like, whoa, this is not the typical fibromyalgia EMG that I'm expecting to get kind of thing.
Do you have any knowledge about whether promulgation of regulations through OSHA or other entities followed? Because obviously it was in at least 2-3 different states. And the United States is not the only place where pigs are processed, so there's obviously international health standards as well.
No, it's a good question. Certainly this company, which was the only one theoretically in the country doing it, just stopped doing it. I don't know if laws were passed saying that you can't do this anymore. I suspect not, because it was one company doing it and they stopped doing it, so they probably didn't see the need to, but I agree with you. I think this is a big warning. You've got to be careful what you're doing with raw meat or raw, animal remains.
Can you comment on why some of the people who had antibody titers did not develop some?
Yeah, no, it's a good question. So there are 34% of the people in the warm room who didn't develop a clinical syndrome. Now, I think this is a spectrum. I think diseases often are a spectrum. So, we identified those that had enough symptoms and enough findings that, we would call it this illness. And as it is, if you look at their symptoms, prickling and tingling, pain, fatigue, it sounds really non-specific. When you put that together and they all have those symptoms, and then they have these EMGs that show these very long distal latencies, it then becomes somewhat more specific. But initially, it wasn't us who recognized the syndrome. It was a translator and a family practice physician. This translator went from one of these exams to the next one of these exams and translated similar symptoms for different physicians and said, there's something going on here. I'm translating the same story over and over again. And, thank goodness for a translator.
This is a technical question, but you guys, for your nerve conduction studies, do you sometimes stimulate the proximal location before you do the distal one?
No, so we pretty much always will start with the distal site and move to the proximal site. It sometimes flips where they put it on the tracing and all that, but we pretty much always start. So, but, different labs have, the EMG lab at Mayo was founded by Ed Lambert, who is sort of one of the fathers of EMG. And he had very strong ideas of how you record your findings. So on our reports, we will only tell you the proximal amplitude on the report. We don't give you the distal amplitude and the proximal amplitude. We only give you the proximal amplitude. We give you the distal amplitude for the sensories, because you lose that, but we give you the proximal amplitude for the motors. But the distal latency is always from the distal site, of course. And
the very first nerve conduction that you showed, I was a little disoriented. If I remember correctly, the circle DML is actually the proximal site. I don't know if I just misread it.
The circle distal latency would have been from the distal site.
Yeah, it was just a typographical error on that slide.
Yeah, well, I'll have to go back and look at it, but it should have been from the distal side. I'm not talking about proximal latencies, so.
Well, thanks for a great talk.
Thank you.